Hello class, welcome to Chapter 13, BLS Resuscitation. After students complete this chapter and related coursework, they will have reviewed the basic life support, BLS, procedures for adults, infants, and children. Please note that BLS knowledge is a prerequisite for the course and that this chapter should serve as a review. Introduction. The principles of basic life support, BLS, were introduced in 1960. Since then, the specific techniques have been reviewed and revised every 5 to 6 years. The most recent review was conducted by the International Liaison Committee on Resuscitation. Elements of BLS. BLS is a non-invasive emergency life-saving care that is used to treat medical conditions including airway obstruction, respiratory arrest, and cardiac arrest. Focus is on the ABCs: airway, obstruction, breathing, respiratory arrest, and circulation, cardiac arrest or severe bleeding. If the patient is in cardiac arrest, then the CAB sequence, compressions, airway, breathing, is used because chest compressions are essential and must be started as quickly as possible. Only seconds should pass between the time you recognize that the patient needs BLS and start of treatment. Permanent brain damage is possible if the brain is without oxygen for more than 4 to 6 minutes. The figure on this slide illustrates the concept that time is critical for patients who are not breathing. If the brain is deprived of oxygen for more than 4 to 6 minutes, brain damage is possible. Cardiopulmonary resuscitation, CPR, establishes circulation and artificial ventilation in a patient who is not breathing and has no pulse. CPR steps. Restore circulation by performing chest compressions to circulate the blood. Perform 30 high-quality compressions to a depth of 2 inches to 2.4 inches, 5 to 6 centimeters, in an adult at a rate of 100 to 120 per minute. Open the airway. Restore breathing by providing rescue breaths. Administer 2 breaths, each over 1 second, while visualizing for chest rise. The figure on this slide demonstrates 2 EMS providers performing CPR. Elements of BLS. BLS differs from advanced life support, ALS, which involves advanced procedures such as cardiac monitoring, administration of intravenous or IV fluids and medications, use of advanced airway adjuncts. When done correctly, BLS can maintain life for a short time until ALS measures can be started. The figure on this slide illustrates the 5 links of the chain of survival. The System Components of CPR. Chain of Survival. The American Heart Association Chain of Survival. Recognition and activation of emergency response system. Requires public education and awareness. Early warning signs of cardiac arrest. Immediate activation of EMS. Immediate high-quality CPR. Early CPR will keep blood and oxygen flowing. Rapid defibrillation. AEDs are readily available. Basic and advanced emergency medical services, CPR, basic airway management, advanced airway management, manual defibrillation, vascular access, transsubcutaneous pacing, administration of medications, advanced life support and post-arrest care, additional medical therapy, targeted temperature management, maintaining blood glucose levels, cardiac catheterization, electroencephalogram to detect seizure activity, admission to intensive care unit. If any one of the links in the chain is absent, the patient is more likely to die. Few patients survive cardiac arrest if CPR is not performed in the first few minutes. Assessing the need for BLS. Always begin by surveying the scene. Is the scene safe? How many patients are there? What is your initial impression of the patients? Are the bystanders who may have additional information? What is the mechanism of injury or nature of illness? Do you suspect trauma? Does the dispatch information match what you're seeing? Complete the primary assessment as soon as possible in order to evaluate the patient's ABCs. First step is determining unresponsiveness. An unresponsive patient does not need CPR. An unresponsive patient may or may not need CPR. This step should take no more than 10 seconds. The basic principles of BLS are the same for infants, children, and adults. An infant is younger than 1 year. A child is between 1 year and the onset of puberty. Adulthood is from the onset of puberty and older. Although cardiac arrest in adults usually occurs before respiratory arrest, the reverse is true in infants and children. The figure on this slide demonstrates how to assess an unresponsive patient by first attempting to rouse him or her by tapping on the shoulder. Automated external defibrillation. AED use is a vital link in the chain of survival. The AED should be applied to a cardiac arrest patient as soon as available. If you witness cardiac arrest, begin CPR and apply the AED as soon as available. AED use in children. Apply after the first 5 cycles of CPR. For children 1 month to 1 year of age, a manual defibrillator is preferred. If this is not available, use pediatric-sized pads and dose attenuating system. If neither is available, then use an AED with adult-sized pads with an anterior-posterior placement. Special situations. Pacemakers and implanted defibrillators. Easily recognizable by a hard lump beneath the skin, usually on the upper left side of the chest. If AED pads are placed directly over the device, the effectiveness of the AED may be reduced and the shock could damage the device. Place electrodes at least 1 inch or 2.5 centimeters away from the device. Wet patients. Do not use the AED unit in water. If the patient is in water, pull the patient out and dry the skin before attaching the AED pads. If the patient is in a small puddle of water or in the snow, the AED can be used, but the patient's chest should be dried as much as possible. Transdermal medication patches. Medication delivered through a transdermal patch. The patch could reduce the electrical current and may burn the skin. Remove the patch, wipe the skin to remove any residue prior to attaching the AED pad. Positioning the patient. For the CPR to be effective, the patient must be lying supine on a firm, flat surface. Must be enough space around the patient for 2 rescuers to perform CPR. If possible, log roll the patient onto a long backboard. Check for breathing and a pulse. Quickly check for breathing and a pulse. These assessments can occur simultaneously and take no more than 10 seconds total. Visualize the chest for signs of breathing. Palpitate for a carotid pulse. Provide external chest compressions. Apply rhythmic pressure and relaxation to the lower half of the sternum. The heart is located slightly to the left of the middle of the chest between the sternum and the spine. Compressions squeeze the heart, acting as a pump to circulate blood. Allow the chest to completely recoil between compressions. External chest compressions, when done properly, circulate only 1/3 of normal heart-pumped blood. Proper hand position and compression technique. See Skilled Drill 13.1. Complications are rare, but include fractured ribs, lacerated liver, fractured sternum. Injuries can be minimized by proper technique and hand placement. The figure on this slide illustrates that the heart lies slightly to the left of the middle of the chest between the sternum and the spine. The figure on this slide illustrates the concepts of compression and relaxation. Compression and relaxation should be rhythmic and of equal duration, a 1-to-1 ratio. Pressure on the sternum must be released so that the sternum can return to its normal resting position between compression. Opening the airway and providing artificial ventilation. Opening the airway in adults. There are two maneuvers to do this. The first one is the head tilt chin lift maneuver. This is used in patients who have not sustained trauma. This maneuver may be all that is needed for patients to resume breathing. Remove any foreign materials in the mouth. The second maneuver is a jaw thrust maneuver, and this is used for patients who have sustained trauma. Place fingers behind the angles of the patient's lower jaw and move the jaw upward. Keep the head in a neutral position as the jaw is moved upward and the mouth is opened. If the patient is breathing adequately on his or her own and has no signs of injury to the head, spine, hip, or pelvis, place him or her in the recovery position. This maintains a clear airway, allows vomitus to drain from the mouth. Roll the patient onto his or her side so that the head, shoulders, and torso move as a unit. Place the top hand under the cheek. Never place a patient with a potential head, spinal, hip, or pelvic injury in the recovery position. The figure on this slide demonstrates the recovery position. A lack of oxygen, hypoxia, combined with too much carbon dioxide in the blood, hypercarbonia, is lethal. Provide slow, deliberate ventilations that last 1 second. If the patient is not breathing, ventilations can be given by 1 or 2 EMS providers. Use a barrier device such as a pocket mask, one-way valve, or BVM. The figure on this slide demonstrates using a barrier device when providing ventilations. For the patient with a stoma, place the BVM or pocket mask device directly over the stoma. Artificial ventilation may result in gastric distension. The stomach becomes filled with air when you hyperventilate the patient. You ventilate too forcefully, the patient's airway is not opened adequately. Have a suction unit available in case the patient vomits. The figure on this slide demonstrates how a barrier device attaches to a stoma. The stoma connects the trachea directly to the skin. Use a BVM or pocket mask device to ventilate a patient with a stoma. One rescuer adult CPR. When providing CPR alone, you must provide a continuous cycle of 30 chest compressions followed by 2 artificial ventilations. The ratio of compressions to ventilation is 30:2. 2 rescuer adult CPR. It is always preferable to 1 rescuer CPR. The rescuer who is doing the compressions can be switched. This is less tiring and facilitates effective chest compressions. Switching rescuers during CPR is critical to maintain high-quality compressions. It is recommended to switch positions every 2 minutes. It should take less than 5 seconds to switch compressors. Devices and techniques to assist circulation. Active compression decompression, CPR, involves compressing the chest and then actively pulling it back up to its neutral position or beyond. Decompression may increase the amount of blood that returns to the heart and thus the amount of blood ejected from the heart during the compression phase. Features a suction cup that is placed in the center of the chest, which the rescuer pulls up to provide active decompression of the chest. Impedance threshold device, ITD, is a valve device placed between the ET tube and the bag valve mask. May also be placed between the bag and mask if an ET tube is not in place. This limits the air entering lungs during the recoil phase between chest compressions. The first figure on this slide is an active compression decompression CPR device. The second figure on this slide is an impedance threshold device. Mechanical piston device. Depresses the sternum via a compressed gas-powered or electric-powered plunger. This results in a constant delivery of compressions. Load distributing band CPR or vest CPR. A circumventral chest compression device composed of a constricting band and backboard, electrically or pneumatically driven to compress the heart by putting inward pressure on the thorax. Manual chest compressions remain the standard of care. The figure on this slide is a load distributing band. Infant and child CPR. In most cases, cardiac arrest in infants and children follows respiratory arrest, which triggers hypoxia and ischemia of the heart. Airway and breathing are the focus for pediatric BLS. Causes of respiratory problems leading to cardiopulmonary arrest in children. Injury, both blunt and penetrating, infections of the respiratory tract or another organ system, a foreign body in the airway, submersion, drowning, electrocution, poisoning or drug overdose, and sudden infant death syndrome. Determining responsiveness. Never shake a child to determine responsiveness. Gently tap child on shoulder and speak loudly. If you find an unresponsive, apneic, pulseless child while alone and off duty, perform CPR for 5 cycles, about 2 minutes, and then call the EMS system. Cardiopulmonary arrest in children is often the result of respiratory failure. They require immediate restoration of oxygenation, ventilation, and circulation. Check for breathing and a pulse. This assessment can occur simultaneously and should take no longer than 10 seconds. Visualize the chest for signs of breathing. Palpate for a pulse in the large central artery. Carotid or femoral artery in children older than 1 year. Brachial artery in infants. The child must be lying on a hard, flat surface for effective chest compressions. Only use 2 fingers to compress an infant's chest. If 2 rescuers are performing CPR on an infant, use the 2 thumb encircling hands technique to deliver chest compressions. In children, especially those older than 8 years, you can use the heel of one or both hands to compress the chest. Follow the steps in Skill Drill 13.4 to perform infant chest compressions. Follow the steps in Skill Drill 13.5 for performing CPR in children between 1 year and the onset of puberty. Airway. Foreign body obstruction in children is common. Place an unresponsive, breathing child in the recovery position. Do not use this position if you suspect injury to the spine, hips, or pelvis. The 2 common techniques for manually opening an airway are modified for the pediatric patient: the head tilt chin lift maneuver and the jaw thrust maneuver. Place a wedge of padding under a child's upper body and shoulders to avoid partially obstructing the airway. Provide rescue breathing. If the child is not breathing but has a pulse, then open the airway and deliver 1 breath every 3 to 5 seconds. About 12 to 20 breaths per minute. If the child is not breathing and does not have a pulse, then deliver 2 rescue breaths after every 30 chest compressions. It is 15 chest compressions to 2 breaths if 2 rescuers are present. Each ventilation should last about 1 second and should produce visible chest rise. If an infant or small child is breathing, then provide prompt transport. Allow the child to stay in whatever position is most comfortable. In a child with a tracheostomy tube in the neck, remove the mask from the BVM and connect it directly to the tracheostomy tube to ventilate the child. A face mask with one-way valve or other barrier device over a tracheostomy site can be used. Interrupting CPR. CPR is a critical life-saving procedure that provides minimal circulation and ventilation until the patient can receive defibrillation, ALS treatment, and definitive care at the ED. No matter how well performed CPR is rarely enough to save a person's life. If ALS is not available at the scene, provide transport based on your local protocols, continuing CPR on the way. Consider requesting a rendezvous en route to the hospital. Try not to interrupt CPR for more than a few seconds, except when necessary. For example, you may have to move a patient up and down stairs. Chest compression fraction, the total percentage of time during a resuscitation attempt in which chest compressions are being performed. Try to maintain a chest compression fraction of at least 60%. When not to start CPR. 3 general rules regarding when not to start CPR. If the scene is unsafe, if the patient has obvious signs of death, which include an absence of pulse and breathing, along with any one of the following findings: rigor mortis, stiffening of the body after death, dependent lividity, discoloration of the skin caused by pooling of the blood, putrefaction, decomposition of the body, evidence of non-survivable injury, example, decapitation, dismemberment, or burned beyond recognition. The figure on this slide is an example of dependent lividity. If the patient or physician have previously agreed on a do not resuscitate, a DNR orders, usually only applies when patient is in terminal stage of incurable disease, can be a complicated issue. Advanced directives expressing patient's wishes may be hard to find. When in doubt, begin CPR. Very important to know local protocol. When to stop CPR. Once you begin CPR, continue until one of the following occurs, using the mnemonic STOP. S. Patient starts breathing and has a pulse. T. Patient is transferred to another provider of equal or higher level training. O. You are out of strength. P. Physician directs you to discontinue. Out of strength does not just mean tired, but physically unable to continue. Foreign body airway obstruction in adults. An airway obstruction may be caused by various things: relaxation of the throat muscles in an unresponsive patient, vomited or regurgitated stomach contents, blood, damaged tissue after an injury, dentures, foreign bodies such as food or small objects. Recognizing foreign body airway obstruction. In adults, foreign body airway obstruction usually occurs during a meal. In children, airway obstruction usually occurs during meal or at play. Mild airway obstruction. Patient is able to exchange adequate amounts of air, but still has signs of respiratory distress. Leave these patients alone. Observe for signs of severe airway obstruction: weak or absent cough, decreasing level of consciousness, and cyanosis. Responsive patients. A sudden severe obstruction is usually easy to recognize in responsive patients. The person is suddenly unable to speak or cough, grasps his or her throat, turns cyanotic, and makes exaggerated efforts to breathe. Stridor may be present, high-pitched sound that occurs when the object is not fully blocking the airway. Unresponsive patients. In unresponsive patients, suspect obstruction if maneuvers to open airway and ventilate are ineffective. Removing a foreign body airway obstruction in adults. Abdominal thrust maneuver, Heimlich maneuver, is recommended in responsive adults and children older than 1 year. This creates an artificial cough. If the patient with a severe airway obstruction is unresponsive, then perform chest compressions. This figure on this slide displays how to perform an abdominal thrust maneuver in a responsive adult. Instead of abdominal thrust maneuver, use chest thrusts for the following responsive patients: women in advanced stages of pregnancy and obese patients. The figure on this slide displays how to perform chest thrusts in a responsive adult. Responsive patients who become unresponsive. Lower the patient to the ground and call for help, or send someone for help. Perform 30 chest compressions. Do not check for a pulse before beginning chest compressions. Open the airway and look in the mouth. If you see an object that can be easily removed, remove it with your fingers and attempt to ventilate. If you do not see any object, resume chest compressions. Repeat steps 2 and 3 until the obstruction is relieved or ALS providers take over. Unresponsive patients. Determine unresponsiveness. Check for breathing and pulse. If pulse is present but breathing is absent, then open the airway and attempt to ventilate. If first ventilation does not produce visible chest rise, then reposition the airway and reattempt to ventilate. If both ventilation attempts do not produce visible chest rise, then perform 30 compressions, open the airway and look at the mouth. Attempt to carefully remove any visible object. Foreign body airway obstruction in infants and children. Airway obstruction is a common problem in infants and children. In patients who have signs and symptoms of airway infection, do not waste time trying to dislodge a foreign body. Administer supplemental oxygen if needed and immediately transport the child to the ED. As long as the patient can breathe, cough, or talk, do not interfere with his or her attempts to expel the foreign body. Administer supplemental oxygen if needed and tolerated, and provide transport to the ED. On a responsive standing or sitting child, perform the Heimlich maneuver, but with less force than what would be used on an adult. An unresponsive child older than 1 year who has an airway obstruction is managed in the same manner as an adult. The figure on this slide demonstrates how to perform the abdominal thrust maneuver on a responsive child. Infants. Do not use abdominal thrusts on responsive infants. Instead, perform back slaps and chest thrusts or compressions. The figures on this slide demonstrate how to perform back slaps and chest thrusts on an infant. Hold the infant face down with the body resting on the forearm. Support the jaw and face with your hand and keep the head lower than the rest of the body. Give the infant 5 back slaps between the shoulder blades using the heel of your hand. Give the infant 5 quick chest thrusts using 2 fingers placed on the lower half of the sternum. In unresponsive infants, begin CPR beginning with chest compressions. Do not check for a pulse before starting compressions. Open the airway and look in the mouth. If you see an object that can easily be removed, then remove it with your finger and attempt to ventilate. If you do not see an object, then resume chest compressions. Continue the sequence of chest compressions, opening the airway and looking inside the mouth until the obstruction is relieved or ALS providers take over. Special resuscitation circumstances. Opioid overdose. If naloxone was administered by a bystander prior to your arrival, then determine how much of the medication was given and the route by which it was given. The recommended algorithm for implementing naloxone into a cardiac management sequence is discussed in Chapter 21, Toxicology. Standard resuscitative measures take priority over naloxone administration. Cardiac arrest and pregnancy. Priorities are to provide high-quality CPR and relieve pressure off the aorta and vena cava. If the pregnant patient is not in cardiac arrest, then position her on her left side to relieve pressure on the great vessels. If she is in cardiac arrest and the top of the patient's uterus can be felt at or above the level of the umbilicus, perform manual displacement of the uterus to the patient's left to relieve the arteriocaval compression while CPR is being performed. Grief support for family members and loved ones. Family members may experience a psychological crisis that turns into a medical crisis. Family members and loved ones will remember this event in detail for the rest of their lives. Appropriate and supportive care at the onset of grief may positively affect the family's grieving process. Keep the family informed throughout the resuscitation process. Designate one provider to communicate the patient's status to the family members. Be concise and clear. After resuscitation has stopped, These other measures can be helpful. Take the family to a quiet, private place. Introduce yourself and anyone with you. Use clear language and speak in a warm, sensitive, and caring manner. Try to exhibit calm, reassuring authority. Use the patient's name. Use eye contact and appropriate touch. Expect the family members will show emotion as they begin the grieving process. While you are still on scene, be supportive, do not hover. Ask if a friend or family member can be called to come and help support them. When you need to leave, turn the family over to someone else, for example, a police officer. Ensure that children are not ignored. See Chapter 2, Workforce Safety and Wellness, for a discussion of emotional aspects of emergency care and stress management. Education and training for the EMT. CPR skills can deteriorate over time. Practice often using mannequin-based training. CPR self-instruction through a video and/or computer-based modules with hands-on practice may be a reasonable alternative to instructor-led courses. Education and training for the public. You are a patient advocate. Not only are you responsible for providing the best possible care for your patient, but you must do your part to facilitate the training of laypeople in the critical skills of CPR and AED operation. If you are asked to train members of your community how to perform compression-only CPR, then you should consider it your professional responsibility and be willing to assist. Okay, class, let's go over some review questions. Review question number 1. Brain damage is very likely in a brain that does not receive oxygen for A. 0 to 1 minutes, B. 0 to 4 minutes, C. 4 to 6 minutes, or D. 6 to 10 minutes. The correct answer is D. Permanent brain damage is very likely if the brain is without oxygen for 6 minutes or longer. After 10 minutes without oxygen, irreversible brain damage is likely. Brain damage is very likely in a brain that does not receive oxygen for 0 to 1 minute. Rationale. Cardiac irritability ensures at this stage. 0 to 4 minutes. Rationale. Brain damage is not likely at this stage. 4 to 6 minutes. Rationale. Brain damage is possible at this stage but not likely. 6 to 10 minutes. Correct answer. Review question number 2. Which of the following sequences of events describe the AHA's chain of survival? A. Early access, integrated post-arrest care, early advanced care, early CPR, and early defibrillation. B. Early advanced care, early defibrillation, integrated post-arrest care, early CPR, early access. C. Early access, early CPR, early defibrillation, early advanced care, integrated post-arrest care. D. Early access, early riser, early CPR, early advanced care. The correct answer is C. The AHA has determined an ideal sequence of events that, if taken, can improve the chance of successful resuscitation of a patient who has an occurrence of sudden cardiac arrest. Early access, early CPR, early defibrillation, early advanced care, and integrated post-arrest care. If any one of the links in the chain is absent, the patient is more likely to die. Early access, integrated post-arrest care, early advanced care, early CPR, early defibrillation. Early CPR and defibrillation come before advanced care. Answer B, the chain is backwards. Answer C is the correct answer. Answer D, early riser is not in the chain of events. Review question 3. For CPR to be effective, the patient must be on a firm surface lying in the blank position. A. Flower, B. Prone, C. Supine, or D, recovery? The correct answer is C. For CPR to be effective, the patient must be lying supine on a firm surface, with enough clear space around the patient for 2 rescuers to perform CPR. If the patient is crumpled up or lying face down, you will need to reposition him or her. The few seconds that you spend repositioning the patient properly will greatly improve the delivery and effectiveness of CPR. Review. A. Flower. The patient is sitting up with knees bent in this position, making it nearly impossible to make effective chest compressions. B. Prone. The patient is lying face down in this position. Correct answer is C. Supine. D. Recovery. The patient is lying face down with one knee bent and head slightly tilted. Review question 4. The pulse check should take A. 1 second, B. At least 1 second but no more than 5 seconds, C. At least 10 seconds, D. At least 5 seconds but no longer than 10 seconds. The correct answer is D. The pulse check should take at least 5 seconds but no more than 10 seconds. Rationale for answer A. 1 second is not long enough to detect a pulse. Rationale for answer B. 5 seconds may not be long enough to detect a pulse. Answer C. 10 seconds is a long time in this situation. The brain should not be deprived of oxygen for longer than 6 minutes. Every second counts. D is the correct answer. Review question 5. Artificial ventilation may result in the stomach becoming filled with air, a condition called A. Gastric distension, B. Vomitus, C. Abdominal thrust maneuver, D. Acute abdomen. The correct answer is A. The artificial ventilation may result in the stomach becoming filled with air, a condition called gastric distension. Gastric distension is likely to occur if you ventilate too fast, if you give too much air, or if the airway is not opened adequately. Therefore, it is important for you to give slow, gentle breaths. Answer A, correct answer. Answer B, vomitus. Gastric distension may lead to vomitus. C, abdominal thrust maneuver. The abdominal thrust maneuver is a method of removing a foreign obstruction from the airway. D, acute abdomen. Acute abdomen is a medical term referring to the sudden onset of abdominal pain generally associated with severe progressive problems that require medical attention. Review question 6. The blank is a circumficial chest compression device composed of a constricting band and backboard. A. Mechanical piston device. B. Load distributing band. C. Impedance threshold device. D. Cardiopulmonary resuscitation. The correct answer is B. The load distributing band is a circumferential chest compression device composed of a constricting band and a backboard. The device is either electronically or pneumatically driven to compress the heart by putting inward pressure on the thorax. As with the mechanical piston device, use of the device frees the rescuer to complete other tasks. It is lighter and easier to apply than the mechanical piston device. Answer A. Mechanical piston device. This device depresses the sternum via a compressed gas-powered plunger mounted on a backboard. Load distributing band. Correct answer. Impedance threshold device. This valve device is placed between the echotracheal tube and the bag valve mask. It is designed to limit the air entering the lungs during the recoil phase. D. Cardiopulmonary resuscitation. This procedure is used to establish artificial ventilation and circulation in the patient who is not breathing and has no pulse. Review question number 7. Which of the following scenarios would warrant an interruption of CPR procedures? A hysterical family member trying to gain access to the unconscious patient. B, a vehicle honking its horn anxious to pass by the scene on the blocked road. C, a small set of steps leading to the exit of a building on the way to the ambulance. D, being tired from trying to resuscitate a patient. The correct answer is C. Try not to interrupt CPR for more than a few seconds except when it is absolutely necessary. For example, if you have to move a patient up or downstairs, you should continue CPR until you arrive at the head or foot of the stairs, interrupt CPR at an agreed-on signal, and move quickly to the next level where you can resume CPR. Rationale for answer A. Family members should be calmed down and reassured that the patient is in good hands. A hysterical family member does not warrant a break in CPR. Answer B. Your primary focus should be on the patient. Let the on-scene police or traffic control deal with upset motorists and blocked roadways. Answer C is the correct answer. Rationale for answer D. CPR should always be continued until the patient's care is transferred to a physician in a hospital setting. Being out of breath does not mean being physically incapable of performing more CPR. Review question 8. Once you begin CPR in the field, you must continue until one of the following events occurs. Answer A. The patient stops breathing and has no pulse. B. The patient is transferred to another person who is trained in BLS or ALS trained personnel, or to another emergency medical responder. C. You are out of gas in the ambulance. D. A police officer assumes responsibility for the patient and gives direction to discontinue CPR. The correct answer is B. The T in the stop mnemonic stands for the patient transferred to another person who is trained in BLS, to ALS trained personnel, or to another emergency medical responder. A. The rationale. These are the reasons to begin CPR. The correct answer is B. The rationale for C. This is not a valid reason to stop CPR. You are out of strength or too tired to continue may be a valid reason. Rationale for answer D. A physician who is present or providing online medical direction should assume responsibility for the patient and give direction to discontinue CPR. Review question number 9. Instead of abdominal thrust maneuver, use blank for women in advanced stages of pregnancy and patients who are obese. A. Chest thrusts. B. Celiac maneuver. C. Basic life support. D. DNR orders. The correct answer is A. You can perform the abdominal thrust maneuver safely on all adults and children. However, for women in advanced stages of pregnancy and patients who are obese, you should use chest thrusts. A is the correct answer. The rationale for B. This technique is used to prevent gastric distension, in which pressure is applied to the cardiac cartilage, also referred to as cardioid pressure. Rationale for C. BLS is non-invasive emergency life-saving care that is used to treat medical conditions. Chest thrusts are a BLS tactic. DNR orders. Rationale. Do not resuscitate orders are specific instructions not to perform life-saving techniques on certain patients who may be suffering from terminal illnesses. DNR orders have to be on hand and can be complicated issues. Review question 10. In infants who have signs and symptoms of an airway infection, you should not waste time trying to dislodge a foreign body. You should intervene only if signs of blank develop, such as a weak, ineffective cough, cyanosis, stridor, absent air movement, or a decreasing level of consciousness. A. Sudden infant death syndrome. B. Child abuse. C. Bronchitis. D. Severe airway obstruction. The correct answer is D. With a mild airway obstruction, the patient can cough forcefully, although there may be wheezing between coughs. As long as the patient can breathe, cough, or talk, you should not interfere with his or her attempts to expel the foreign body. As with an adult, encourage the child to continue coughing, administering 100% oxygen with a non-rebreather mask, and provide transport to emergency department. Rationale for A. Death of an infant or young child that remains unexplained after a complete autopsy. Child abuse. The obstruction may be a result of child abuse, but these signs are those of severe airway obstruction. Bronchitis is the inflammation of the lung. It is not a direct result from a foreign body lodged in the airway. Correct answer is D, severe airway obstruction. Okay, class, this concludes the lecture on Chapter 13, BLS Resuscitation. Thank you for listening. If you have any issues or questions, please contact your instructor, and I'll see you in the next chapter.